Sir, we are live now.
Yeah, you can start.
Very good evening, one and all. I am Arpita from the IGCP group, and I welcome everyone to the webinar on the topic Thrombus, the Hidden Dragon Challenges in Complex Carotid Interventions. And to present the topic, we have with us someone very eminent from the field of cardiologist, Dr. Kesava Murthy CB, sir. It's an honor for me to welcome Sir to our platform and to introduce him to everyone. Sir has done MD in General Medicine, DM Cardiology, DNB Cardiology, consultant at Manipal Hospital, Mysore. So, with this introduction, sir, I would request you to please start with the topic for today. Over to you, sir.
Thank you very much, and immense gratitude to the IJCP group for this invited presentation. We have started a series of case presentations to make the discussion interesting. A warm welcome to all the participants who are here and spending their time with us in this exercise of getting to learn something and using that knowledge in our day to day practice to improve the outcomes of our patients. If there are any issues with the audio or video, you just stop and tell me. Audio is clear? Yeah. So I would like to give a brief introduction on how thrombus plays a very important role in the lives of interventional cardiologists, neurologists, and the entire medical fraternity. We all know that a little bit of thrombus is necessary for life to contain the blood in the circulation. When there is a disruption of continuity of the blood vessels, thrombosis is a protective mechanism. But when it goes out of hand or occurs inappropriately or occurs in a large volume, then it causes the threat to life. In fact, we can go ahead and say that one of the most important and the leading cause of death worldwide is the presence of thrombus. If you imagine all the cardiac disorders, the acute myocardial infarctions, acute coronary syndromes, acute strokes, they are all thrombus related illnesses. Of course, on the venous side, there is a very fatal and morbid and mortal condition of deep vein thrombosis and pulmonary embolism. And in certain situations where there is an indirect thrombus which leads to death, like for example, patients, say the renal patients, they have a high risk of thrombosis, develop a cardiac event and die. About 80% of kidney disease patients die due to a cardiac event. About 10% of all deaths, pregnancy related deaths, are due to deep vein thrombosis. Like this, thrombus affects various aspects of life of a cardiologist, and therefore we need to be constantly aware of where this hidden dragon can present itself and cause a serious illness in our patients and how to deal with it. We have, of course, understood the mechanism of how thrombosis occurs, the intrinsic, extrinsic clotting pathways, and we have a large armamentarium of drugs to treat thrombus, the antithrombotics, the newer anticoagulants, and so many other drugs are now available. Very potent drugs, especially the antiplatelet therapies, which are now available. But we are still not able to fully resolve the effects of thrombus. What I mean by that is whether you treat a thrombus mechanically or pharmacologically, still there is some effect of the thrombus. If you remove the thrombus from the circulation, there is distal embolization. There is already the effect of thrombus being there for a certain amount of time, which has already caused ischemia and infarction to the tissues. And how it resolves, what is the effect of thrombus on distal circulation, all these are factors which are still poorly understood. So we continue to learn to deal to how best to deal with thrombus in certain clinical situations. And in that direction, today I'll present a case of a very complex carotid intervention in this 71-year-old gentleman, a diabetic, current smoker, hypertensive, dyslipidemia. He had no coronary symptoms. He had a sudden onset of left-sided weakness. Power was grade 1 in the left limbs. Left leg was hardly he was able to move. Left upper limb he was able to move a little bit. Hemodynamically stable. Patient was thrombolized because he came within the window and he was thrombolized and taken up for an angio and possible intervention. So the first angiogram showed this picture. There was a very critical stenosis in the internal carotid artery. If you can see there at the origin of the internal carotid artery, you can see a very critical narrowing. So in that situation, An attempt was made to see the distal circulation, and distal circulation showed a thrombus which had migrated distally to the middle cerebral artery with any flow. There was no filling of the vessels here. So, in the primary sitting, an attempt was made to pass a balloon catheter and achieve some flow at this level. And nothing much was done to the internal carotid artery stenosis at this time, thinking that hyperperfusion syndrome or bleeding complications would occur. Some flow was obtained in the middle cerebral artery with partial filling of the ACA and the MCA, and patient showed some clinical improvement at this stage. Patient had grade 2 power, and therefore a patient was shifted to ICU and kept on antiplatelets. About 48 hours after this, patient developed another CVA, another stroke, in that the limbs again became totally paralyzed to grade 1, and patient became restless and a little bit disoriented, and what was clinically thought of as another stroke. So patient was taken up for a carotid intervention this time, thinking that the internal carotid artery is the culprit. So if you see in this picture, the internal carotid artery is completely occluded, which is a somewhat unusual finding in the cranial circulation. So if you see, this is the external carotid artery, which is continuing. This is the internal carotid artery, which has completely become like a stump. And what circulation was present has got completely occluded because of a thrombus. So this time we were more prepared. We went ahead with an intervention. This you can see the total occlusion. This is the external carotid artery, which you can see there. So we went ahead and passed a wire through this total occlusion blindly, and then we put a distal protection device. Since we knew the type of stenosis, we could pass the distal protection device. This is a Spider FX device which we have placed here. You can see the filter which has been deployed in a relatively straight portion of the internal carotid artery, and this is the wire. So now you can see this huge thrombus. Once we pass that, you can see the critical stenosis and also the large thrombus burden. So then we took a special type of stent which is called as a C-guard stent, which is a small cells, and it also has a coating on it which prevents plaque prolapse and helps us to prevent the thrombus from getting into the circulation. So we deployed this particular stent. It's a tapering stent, if you can see there. That was the narrowing there. This is the internal carotid artery portion. This is the common carotid artery portion. So soon after deployment of the stent, we saw that in the check angio there is a large amount of thrombus. You can see that mobile opacity which is present here. This is a large segment of thrombus in the internal carotid artery, which has probably migrated from this site of initial thrombosis. So at this point, there was a dilemma on what to do with this kind of thrombosis, because if you try to get in and aspirate, there may be distal embolization causing more damage to the brain. Just give some additional agents there, like integralin or the other intravenous antiplatelet agents, or just to give anticoagulation and leave the patient alone. These were the kind of thoughts that were there, but we were not satisfied with the result and thought that leaving such a big thrombus in the common carotid is in the internal carotid is a harbinger of further thrombosis. So we thought we'll do something. So we passed the same Neuromax catheter which we had used for the procedure into the internal carotid artery right up to this portion, and then aspirated the whole segment. So with that clot aspiration, almost 4 pieces of large clots came out through the aspiration, and after aspiration there was a significant improvement in flow, and you can see that the radio density has come down quite significantly distal to the stent. Now there is a reasonable flow, except there you can see some thrombus at the edge of the stent. And luckily, the patient had a significant clinical improvement. Patient had a little bit of a pain in the temporal area, but his limb power improved. Patient was conscious and continuously talking to us. We keep the patients awake during carotid procedures. And if you see, the intracranial circulation is also pretty good with no major vessel occlusions. So this was the result of this particular case, particular intervention. Patient became better, and we shifted into intensive care and observed him for about 48 hours. Patient gradually improved. We did post dilate with a 5 mm balloon because there was a severe narrowing, and thrombus aspiration, good flow was obtained. Patient was kept on dual antiplatelet therapy. So, what was special about this C-guard stent? C-guard stent is an innovative monorail, self-expanding, open cell, PET coated. There is a micro mesh around the stent. This is the micro mesh which is present on the outside of the stent, and it has a pore size of 165 microns as compared to the other cells. Especially the open cell stents have a large open cell through which there can be plaque prolapse, thrombus can migrate into the stent and go into the get carried into the distal circulation. So this stent seems to have some advantages in terms of less distal embolization, less plaque prolapse by plastering the thrombus to the wall of the vessel. That's why we have been using these stents, especially in the thrombotic carotid lesions. So this is how it deploys. This is the distal end. As you deploy, the micro net stent is deployed in this way, and it holds the plaque to the sides. So the filter we used was a spider RX filter. Material is a nitinol mesh and a pore size of 70 to 200. These are the particles which are caught in the spider effects. Of course, there are other protection devices, but use whatever you are familiar with, because in the carotid you cannot spend too much time putting devices in, and especially if you are unfamiliar in deploying the device. Once you enter the carotid, finish the procedure quickly and get out of that zone. So patient had a marked clinical improvement with grade 4 power in limbs, and actually patient walked home, and he is well at about 2 weeks of follow-up now. So what are the lessons learned from this case presentation? Awareness about thrombus in acute clinical settings and how to handle them. Like I said in the first slide, thrombus behaves like a hidden dragon. Sometimes, depending on the age of the thrombus, if it is very early in the stage, if patient comes within a few hours, it responds very beautifully to thrombolysis. You cannot even see a trace of thrombus with the thrombolytic agents alone. But in many of the situations, especially in our country where late presentations, patient come out of the thrombolytic window, especially in the coronary situations, they come after 12 hours or 24 hours, the thrombus hardens, and then it becomes a difficult monster to handle. Handling it, touching a thrombus causes distal embolization, there is incomplete resolution, there is release of various vasoactive substances at the site of thrombus, which puts the vessel into a severe state of spasm, which leads to various complications, vascular complications. So, therefore, thrombus handling should be multiple approaches. You have to use distal protection where appropriate, especially in the cerebral circulation, in saphenous vein grafts where the thrombus burden is large. Use distal protection, though the evidence is borderline in many of the conditions, even in acute stroke. Some of the studies are contradictory with respect to use of distal protection, but we should still use them. And my personal preference is to use a distal protection wherever you can pass a distal protection without a predilatation. If you can pass a distal protection device, I will always put a distal protection device. So when you choose a stent, choose the closed cell design stent so that the thrombus gets held there. Especially if there is a micronet stent, please use it. That seems to reduce the risk of distal embolization. Use all the pharmacology upfront, like dual antiplatelet therapy, whatever is appropriate. In coronary circulation, we give intravenous antiplatelet drugs for quick and assured action of the antiplatelet drugs, and there is no resistance to them. So we get a quick onset of antiplatelet action within 15 minutes of administration of the drug, and thereby the pharmacological action is also very important. And whenever there is a thrombus, always expect a vasospasm. So spasmolytic agents like nicorandil or whatever agents you want to use in the cerebral circulation, use these agents and handle a thrombus very gently, especially when you see a thrombus and you are instrumenting through a thrombus. If you are going through a lesion containing a thrombus, either when you are passing a balloon and trying to inflate the lesion, be very gentle, do not go to high pressures, do not be very aggressive with the dilatations. And even when you place the stent, very slow deployment of the stents, careful deployment of the stents without push or pull, which may lead to embolization. And avoid post dilatation. In many cases, if you get a sufficient lumen and if you have used a self expanding stent, the stent continues to expand because of its radial force. You need not optimize a stent like you optimize a balloon deployable stent in the coronary circulation. In the cerebral, in the carotid, You can leave those self-expanding stents; they will expand to their usual size over a period of few hours, even few days. They may continue to expand because of that continued radial strength. So the whole thing is gentle handling, avoid aggressive ballooning, use all the measures that are available with you pharmacologically, mechanically. You treat the thrombus gently when it is gentle. You have to be sometimes aggressive with respect to aspiration. We used to routinely aspirate coronary thrombi earlier, but then we realized that that is not working. There is distal embolization, slow flow, no reflow phenomenon. There is not much difference in myocardial salvage. There is an increased risk of stroke in the earlier coronary studies. But with the newer ones, where a mechanical type of thrombosuction, mechanized type of thrombosuction is being used, there seems to be some better results, especially when the thrombus burden is huge and the vessel is large. So mechanical seems to have some role, especially in saphenous vein grafts or large veins which have a large volume thrombus aspiration may work better. So use all these, treat the thrombus as gently as possible, and when aggression is needed, be aggressive, aspirate it, get it out of the way, and get good circulation. So that is the key point, and thank you all for your attention for listening to this complex carotid case presentation. If you have any opinions and questions about this particular presentation, you are free to ask, and also about thrombosis in the coronary and cerebral circulation. Thank you all for the patient hearing.
Thank you, sir. Thank you so much for such an insightful presentation. Now, let us see what are the questions that have come to us.
Yeah.
So the first question is, how do you balance anti-thrombotic therapy in these cases, especially in patients with a high bleeding risk or a recent stroke?
Absolutely. This is one important clinical situation where many a times we are in a dilemma. If we see a large thrombus burden in a carotid setting, always the risk of bleeding is at the back of our mind. Especially when you open the vessel, there is a risk of hyperperfusion. And if already there is a large infarction, by the time you go into the intervention, these ischemic infarct can rapidly become hemorrhagic infarcts. So generally, we give dual antiplatelet therapy in the initial phase and observe these patients, and that's it. If you add a NOAC to these patients, it is only in situations where NOAC is indicated independently. Like for example, if patient has an atrial fibrillation or he is already on NOAC for some indication, then we give that triple, like in the coronary, for about 30 days, and you shorten the period of triple therapy because, as we all know, the risk of bleeding becomes very high when you use three agents, two antiplatelets and one NOAC or oral anticoagulant. So most of the clinical situations we manage them with dual antiplatelet therapy.
Right, sir. Thank you so much for answering this. Going on to the next question, it's so in your experience, how do imaging modalities like the IVUS or OCT influence decision making in thrombus laden carotid lesion?
Absolutely. The coronary circulation, we can use coronary imaging. In neuro, there is intravascular imaging is very less. It is now coming up for peripheral users. We have now peripheral ultrasound and OCT for peripheral vessels also. But in the coronary circulation, definitely the use of imaging is extremely useful. If you see only a thrombotic lesion and treat the thrombus and repeat imaging again, if you see that in many of the cases, once the thrombus has resolved, there is no residual lesion at all. And if you see the plaque composition, if it is an unstable ruptured plaque, you will stent them. Otherwise, if the vessel is clean, you can leave them without a metal also. So it definitely guides you with respect to what kind of therapy you proceed with in these thrombotic cases.
Right, sir. Uh, there are two more queries. Sir, are there specific clinical or angiographic predictors that help you anticipate thrombus-related complication before intervention?
Yeah, absolutely. If you see a large volume thrombus, this is a definite sign that you are headed for a no reflow or distal embolization. And like I said, the symptom status of the patient. Suppose the patient has come quite late, the part of the thrombus would have organized, and therefore it becomes difficult to all modalities. Whether you give them thrombolysis, whether you give them intracoronary or intravascular agents, or you try to aspirate it, it becomes very, very resistant to treatment. So all these factors you have to keep in mind. Angiographically, the volume of thrombus seems to dictate your decision on what to do. If it is just a stenosis related thrombus, especially in coronary circulation, if you see a severe stenosis, once you establish flow, once there is an occlusion and there is some amount of thrombus, once you uh, relieve that obstruction and establish coronary circulation, that establishment of brisk flow itself resolves the thrombus in most of the cases. But if there is a long segment, large volume thrombus, the thrombus burden seems to determine the nature of outcomes, especially with respect to no reflows, slow flows, distal embolization, myocardial delayed myocardial recovery, loss of myocardial function. All these are determined by the volume of thrombus.
Right, sir. One last question. So, can you please share any particular challenging case where thrombus management significantly altered your approach or outcome?
Yeah, this was one such case we have presented. There are many more, of course. Suppose you see a thrombus in the left main artery and an ostial LAD, and there is a large circumflex arising at the same bifurcation point. You are in a real dilemma. It's a real crossroad what to do with this patient, whether to get the patient out of the cath lab, give them some intracoronary agents or intracoronary lytics, because in this situation you know that passing of a balloon or a wire or putting a stent will lead to compromise of the side branch and possible patient death, because the thrombus definitely will migrate into the side branch. So these are all challenging clinical situations, and in many of the cases you have to take a decision at the bedside. If patient is cardiogenic shock, you have no other option. You have to go ahead, aspirate the thrombus, get as much as thrombus out of the circulation, then give a intracoronary lighting, especially tenecteplase has been shown to be very effective. Then use some distal protection device, use mechanical aspiration into both the vessels, and then try to stent. If you can avoid metal, if you can avoid more intervention in the presence of the thrombus, it's good enough. But if you find a very severe stenosis with persis, then you may need to stent that. So treatment is highly individualized, but these are some of the challenges which you see in the real world.
Right, so these were all the queries for today. So, thank you so much. We are really grateful for your time, expertise, and the engaging session that you have delivered. Looking forward for more such sessions in the future, sir. Thank you
Definitely.
so much. So, with that, I would like to conclude our session for today. Thank you so much, sir.
I hope it benefited the audience in some way and
Yes, yes,
elevated
sir.
the quality of practice. Thank you.
Definitely, definitely. Thank you, everyone, for the engaging questions. Thank you all.